for the younger generation are much, much better than what they were, let us say, 20 years back. So when we were learning the technique, there was no station approach. Station approach came much later, I think 2006 or 2007, and it became the standard approach. Um, while I was training students, I have been training them for more than a decade now, I realized two issues. One is that if I give them a chance to enter duodenum, occasionally there will be a problem. We have had two perforations. And second, it was much more difficult initially to make them understand the anatomy. So we started working on a simpler method. This method would allow us initially to just do EUS from the stomach to understand the anatomy of the pancreatobiliary system. And we went through various anatomy manuals and continued, and then of course we published it. The idea is to look at the entire pancreas from the stomach. I'm sure this idea, when it came to me, was not new, and many people must have done it before, but it was never made into a centerpiece. And the station approach sort of divided the EUS technique, linear EUS, into screening from stomach, screening from duodenum, and multiple stations. So we tried to make it into a simpler method for people to understand. And we started training from last 3 years, and I'm very happy to say that the number of procedures required to train a student now with railroad have come down drastically, almost by 50%. So my students are doing pretty well at the end of 50 procedures. And by the time they are doing 100, I don't have to actually supervise them. So this is the method I'm going to describe to you over the next half an hour. Very, very basic I'm going to talk, starting from the scope handling. So if you're seeing the screen, this is how I use my left hand. The left hand handles the scope, the main part of the scope. You see the three fingers are holding the scope, and the thumb is the one which is used to maneuver the controls. It is very important that the other side of your hand also is used to, use control. So your right hand is free. You see, if you use both the thumb and the middle finger, the right hand becomes free for you to maneuver the scope. So this is how I use my left hand. The right hand is onto the shaft, and it is a very, very important function. Most of the times I am holding it very soft. You can see I am not actually holding it. I am just pushing it right and left, little bit twisting it with two fingers. So most of the time this is what I do with the right hand. Sometimes, of course, you have to hold the shaft firmly and twist. That is, if you are looking for the tail of the pancreas, or if you are looking for the uncinate process from D2. Otherwise, most of the times, soft rotation is what is required. So this is an important movement. When we were learning, we were taught to move our body. I know there are still endosonographers who believe that body movement is very important. I think I'm a very lazy man, so I believe in minimal movements, not too much movement of the body. So my position more or less remains the same. You see, the shoulders are also not moving. I am using it, you see, the two elbows, and you see both the hands. So both these hands actually are like you're driving a car and your wheels are on, both the hands are on the wheel. So if I show this to you again, so there is a synchronistic movement of both the hands. This is very, very important so that you minimize most of the acute angulations. So this is a major movement which I tell my students to learn. So I already told you how we developed the railroad approach. We believe that we are able to teach in a shorter duration and with lesser number of procedures, and of course with no duodenal perforation. Um, So let us start. I will continue to contrast this approach with the station approach. This is not to say that station approach is not good. It's an excellent technique, and there are many other techniques. If you go on YouTube, there are many enthusiastic friends of mine who have developed variations of these techniques, and all of them are good. But ultimately, you have to see all of them and create your own approach and keep learning. I think that is what it is all about. You will find some things of what I do good, take them. Some things you will not find good. So take it from somebody else. And in the end, get everything together and create your own method which suits you the best. So I think that is the way I learned, and that is how I would ask you to go about learning the linear pancreatability EUS. So analyze, go into the anatomy initially, and then look at lot of videos of all the experts. Rajesh has videos, Sundeep has lots of videos, lots of other people have put videos on YouTube. Look at their technique. There are few things that you have to remember when for those of you who are just starting. The first part is about learning the endoscopy part. So passing the endoscope from the cricopharynx all the way till to T2. It's not a very difficult thing nowadays. The scopes are much better, much more flexible. You can learn it pretty easily. The only thing you have to remember is that there is a ultrasound at the tip of the scope, which is little away from where the vision starts. So that understanding takes a bit of a few procedures to develop. Once you have that, I think you can easily maneuver the scope. Once you are comfortable maneuvering the scope, and when I teach, I tell them initially to go only till the antrum and not go beyond that. Later on, when I'm confident in their techniques, I ask them to go into the duodenums. So once you know how to maneuver the scope properly, the second important thing is how to understand the ultrasound images. So we are gastroenterologists, we are exposed to ultrasound, but not so much. And the EUS images are very different from abdominal ultrasound images. So you have to learn to identify various structures. This is also a relatively easy thing, and you very fast after watching EUS videos on YouTube and after doing a few procedures, you will see that you are recognizing what is liver, what is pancreas, what is kidney, what is adrenals, spleen, all those things. It's an easy thing to do. That is the second step. The third, and that is the most important step, is to get the correct windows. So there are multiple methods of getting the correct windows. For example, if you want to visualize the gallbladder. So there are many methods of this. You can do it from the stomach, you can do it from the duodenum, bulb, multiple areas. But scanning and understanding what movement of your echo endoscope brings a perfect image. This is a constant learning. It takes a lot of time. And there are many things involved in this. The most important thing which I found was correlation. So initially, if you mistake that an organ for something else, always look for correlation. So if you are thinking that this is a splenic artery, for example, and you are not sure whether it is splenic artery or vein, of course you can put pulse Doppler and look at whether it is artery or vein. The other thing, and which I find better to do, is trace it. That way you will learn fine movements also. So trace the splenic artery all the way towards the spleen and trace it all the way towards the aorta. And that way you will learn fine movements, and you will also be more confident of your anatomy. So if you are tracing the splenic vein, trace it all the way towards its junction with the superior mesenteric vein, and then trace the portal vein all the way towards the liver. So that following a vessel or an organ and correlating it with other things. So for example, when you are looking from the duodenum, you know that you should look at, you should see portal vein, you should see bile duct, you should see pancreatic duct. But sometimes you also see the gastroduodenal artery. So you have to understand the correlations that in the duodenum, the CBD is closer to the transducer, the portal vein is away from the transducer, and a correlation brings you to a point where you can instantly recognize an area. The moment you see a portal vein and CBD together, you know that, okay, you are in the region of suprapancreatic bile duct. If you are seeing bile duct coming closer to the pancreatic duct, you know that you are coming closer to the papilla. So this correlation develops automatically, but this is the one thing which you need a lot of time, getting a correct window and getting a correlation so that you understand the anatomy. Reading anatomy books, we read Gray's Anatomy and everything while we were learning. It helps, but you don't have to be uh, too deep about anatomy. Of course, some of my friends love anatomy and they will tell you each vein and artery and arteriole and everything. If you are interested in that, it is perfect. Please go for it. But for practical purposes, for clinical utility, you need a basic knowledge of anatomy and understanding. So, for example, here you see this is the IVC and this is the aorta. Now, the IVC lies behind the head of the pancreas. You can see here, while the aorta lies behind the uncinate process. Such small things, you don't have to know much, but the relationships of arteries, veins to the major structures which we need to encounter and where we practice pancreas, bile duct, CHT, liver. So you should know the liver anatomy, you should know the segments of the liver, and you should learn how to identify these segments on EUS. So that is important. So understanding of the anatomy, all these things take a little while to develop, but once it is developed, it is pretty fixed in your mind, and there should not be much of the problem. The another tip which I like to give you when I watch my trainees, my friends who come to learn from me, is the movements are often very exaggerated. I think they have seen some very dramatic videos, and so if I ask them to turn anti-clockwise, they straight away turn 90 degrees anti-clockwise. Now, 90 degrees for an EUS scope is a huge, huge area. It will take you through so many structures. So, your movements, you have to learn to make millimeter movements, and that is how you will understand the anatomy better. So if you are introducing the scope beyond the G junction, do it at a very small pace. Don't straight away go all the way till enteral. Go 1 centimeter. Try to understand what is the structure that you are seeing. If you have to turn clockwise, don't turn clockwise instantly to 90 degrees. Do a slow, deliberate, lazy movement, and that will bring you a much better understanding of the structures that are there when you turn clockwise from G junction. Likewise, when you turn anti-clockwise, do it slowly, very deliberately. Uh, Ultimately, you will learn that it is a mixture of multiple movements, as it is in driving a car or it is in doing ERCP. That there are multiple small movements which combine to give you the best effect, and you will have to do a little bit of clockwise, little bit of introduction, little bit of withdrawal, little bit of up movement, little bit of down movement. That will come with practice, but at the end of it, you should understand that there is only a limited range of movements that is available to us, and we have to get the best of the images from those movements. So movements have to be small in caliber, not large in caliber. Should not be expansive movements. That is another tip that I would like to give you. So let us start with these tips. So I start from the GE junction. See this? When you put your scope, start from the GE junction, and this looks a lot of length, but you go by for about 5 to 7 centimeters beyond the GE junction, and you will see the entire pancreatobiliary system. So if you see this, you are starting from the left lobe of liver. Once you see the left of the lobe of the liver, you will see the hilum. Then trace the bile duct all the way down. Then look at the head of the pancreas, and finally body and tail of the pancreas. So the alpha, if you see what I call alpha, is it starts from here, goes like this, turns here, and turns like this. So this is the alpha that we do. The descending alpha, the loop, and here is the ascending or the horizontal alpha limb. So this is how we do the pancreatobiliary from the stomach. This is how you see. We begin from the liver, identify the hilum, identify the portal vein and bile duct at the hilum, trace the bile duct and portal vein down towards the head of the pancreas. So this looks a longer move. It's not so much that you have to push, probably 3-4 centimeters. Once you have seen the head of the pancreas, evaluate the head of the pancreas, look at the SMB and the confluence. Above that is the neck, body, and tail. So once you've examined the head, turn 100 degrees and look at the body and tail to end the procedure. Then, of course, you can reverse from end, come to the beginning, and that completes the cycle. I will just show you a few videos. So you see here, once you are at the GE junction, and if your scope is a little anti-clockwise compared to neutral, you will see left lobe of liver somewhere here. Once you see the left lobe of liver, you will see that there are hepatic veins, there are biliary ductal radicals and arterial radicals. You can try to identify with Doppler, not really necessary. From here, you turn clockwise. Once you turn clockwise, you will see that the arterioles and the venous radicals and everything start converging towards the hypoechoic area somewhere around here. This is the segment 2 you will see, and then you will see the hilum. If you turn too much clockwise, you will see the IVC. So if you are at the IVC, you may have to turn a little anti-clockwise to see this window where you are seeing the portal vein, the common bile duct, and the hepatic artery, which is not seen so well here. So this is the hilum. From here, you can either first concentrate on the liver, identifying the liver completely, right, the left lobe segment 2 and 3, or you can turn to the other way and start looking at the common hepatic duct, common bile duct, gallbladder. So once you have got this, you have to get it in a horizontal position like 6 o'clock. Now you see this is the bile duct, this is the portal vein, and this is the gallbladder. So are you understanding the anatomy, how we are looking at this anatomy? So if you are looking at a CT scan, this is not how you look. So this is like a sleeping patient. If you have a sleeping patient, then this is how the left lobe will look. And below the left lobe, you will see the portal vein and the CVD traversing down. This is the gallbladder. You see the cystic duct here. So once you have seen this, you can use Doppler initially. Please use Doppler. There is no problem. And I'll fast forward this. See, this is the liver here, gallbladder here. Once you have done that, then you have to just push the scope downwards, follow these portal vein and the bile duct till you see the edge of the pancreas. See, this is the pancreas, typical salt and pepper appearance. You have the portal vein, you have the bile duct entering behind the pancreas. So you have reached the head of the pancreas. This is a very important landmark for, especially for patients with tumors of head of the pancreas. So you have to learn to properly delineate this area. Once you have seen this, now you will see, try to make the SMV horizontal, 6 o'clock. So you will need a little bit of clockwise maneuver for that. I have chosen an easy case for you. You can see a stent inside so that you can understand. Now here, the anatomy is like, this is the confluence. This, you see here, is the gallbladder. You have the liver underneath, the gallbladder. You can see this air. This air is the air between the gallbladder and the pancreas. Now try to understand the anatomy from the CT scan. You have the gallbladder, liver above, gallbladder underneath that the duodenal bulb. So this is the duodenal bulb, and underneath that the head of the pancreas. So this is how the anatomy is twisted, almost I would say 180 degrees. So this is air in the duodenum. So let's see. The duodenal bulb will be around here, and okay, I forward it. Gallbladder, CBD, and the confluence. So you have reached the head of the pancreas. Now let us go to the next video. It's the same patient. Once you have reached the head of the pancreas, you see this air. This is D2. So the papilla will be somewhere around here. You see we are tracing the bile duct, easy in this case because there is a stent inside. So for this, what you have to do is gentle up and clockwise movement. So you see here, my scope is almost lying on the head of the pancreas. That means I am using extreme up angulation. So once you are using up angulation, the pancreas comes towards the transthyretin, and you use it gentle clockwise and at the same time push a little in. So this is the C of the duodenum. See, we will see it better probably later. So this is the C of the duodenum. You see this is the air in the duodenum. Now you see this area forming. This is the papilla. I'll fast forward it for you to see. See here, this is the papilla forming. All this we are seeing from the stomach. Remember, we are not seeing it from the duodenum. So this is the bile duct. You see here, always use Doppler if you are confused. And this looks like there is a small tumor here. We'll identify it better. So once you have identified the head of the pancreas, you have to turn extreme up, clockwise, and push down a bit. And you will reach till the papilla. And you should also see, is it the same video or is it a different video? Okay, so this is the bile duct. See here. You are now seeing a very big vessel underneath it. See this? This is the IVC. As I told you, the pancreas head overlies the IVC. And you see this tumor, very well formed, nicely seen hypoechoic tumor, again seen from the head of the pancreas. This is the pancreatic duct. Above is the SMV, and this is the head of the pancreas. So we have a small tumor at the ampulopancreatic area. You can see it is invading the pancreas. You can always use the pulse Doppler to see whether it is IVC or whether it is aorta. So you are seeing the bile duct and the pancreatic duct entering this tumor. You are seeing air in the duodenum. If you push a little further, you will see a circular duodenum here. You see here, this is a circular duodenum, and you will see the SMV going above the duodenum at the level of D3. So now what we have seen is this patient has a dilated pancreatic duct. Rest of the pancreas appears normal, but we have not seen the uncinate process as yet. We have seen the IVC underlying the head of the pancreas. So continuing with the same patient, we have already identified the tumor, we have identified the aorta. Now you twist the scope clockwise with your right hand and you will see the aorta. Again, use pulse Doppler to confirm if you want, but this is the aorta. And between the aorta and the mesenteric vessels, you see this tongue-like structure. This is the uncinate process. You will never see it so well from D2, I can guarantee you. It is seen beautifully, just like how it is described in Gray's Anatomy from the stomach. So you have the mesenteric vessels and you have the aorta, and if you are lucky, sometimes you see a left renal vein at the apex where the SMA joins the aorta. So this area is the uncinate process. So we have seen the head very well. We have seen both the ducts. We have seen the IVC, aorta, all relations, and we have seen the confluence from the stomach. Now I'll give you a quick examination. See how it goes. This is the body of the pancreas. See here. You see the pancreatic duct. This is the pancreatic duct. Kidney, left adrenal, left adrenal, turning more clockwise now. You are seeing the aorta coming, turning more clockwise and withdrawing. You are seeing the spleen. So this is the descending loop. Then turn anti-clockwise, trace the splenic vessels above the kidney. You are seeing the pancreas body again. You see the pancreatic duct. See the pancreatic duct. I am going advancing with a little anti-clockwise and down movement. This is the confluence, beautifully seen. And you see the pancreatic duct coming down. See this? This is the pancreatic duct. And here is the confluence. See, this is the confluence. Beautifully seen. Neck of the pancreas, head of the pancreas. A large dilated bile duct here, dilated pancreatic duct here. I am pushing my scope, looking towards the papilla, pushing towards the papilla. This is the papilla. You see a nice, beautiful hypoechoic tumor here. See this? So this is the alpha maneuver. I hope I was able to make you understand it. Um, I have another videos, but I think we are short of time, and I can show you later on. Some of my videos are on YouTube. So like this video is a very useful video. Just type alpha maneuver on the YouTube. I'll just show you my position more than anything else. See here. So this is the, I'll reduce this. See. So stand away from the patient. I stand almost a foot away from the patient. The neutral position is like this. This is the neutral position. Then you turn your wrist anti-clockwise or clockwise. So if you turn it anti-clockwise, see this. This is how you will see the anterior structures. That is the liver, the gallbladder, and then if you want to see the posterior structure, which is the body and tail of pancreas, you have to turn your scope clockwise. So once you turn clockwise, now you see we are here. Now if you look at the movement that I am making, these are minimal movements. I never make maximal movement, very lazy I am. So you see minor movements will make major differences here. There are no major movements happening, but you see how the windows are changing with little movement. So this is what you have to learn, and I will not go into the details of this video. It is there on YouTube, but all I wanted to show you is that the movements are gentle, small, and they make a major difference. So happy learning, and don't think that what I am telling you is the best. Please go to the YouTube, look at all the other stalwarts video, and create your own method. See here, this is the alpha maneuver. This is the head of the pancreas here. This is the pancreatic duct. Yeah. See here, head of the pancreas, SMV. And here, you see, the movements are hardly there. I am anti-clockwise, little clockwise. You see the pancreatic duct, you see the duodenal sea, IVC, aorta. See this is the aorta, head of the pancreas, SMV, uncinate process here, as I described to you just now. So when I go towards the tail, when I want to go towards the tail, you see this hand will turn clockwise. So look here now, this is the body. I am tracing the pancreatic duct here, and then There is a slow clockwise. So when you watch this video, concentrate on the hand movements and what is happening correspondingly here. You will see that you have to make small movements, not major movements, at least in the beginning. Thank you very much. I think I should stop my presentation here, and I'll ask Sundeep. Rajesh is going to talk next on uh, contrast EUS. How do I do this, Sundeep? Should I remove this, my presentation now? Okay. Now, I can't hear you. Yeah, Rajesh, please start.
You have to remove your slides.
I removed.
You removed?
Yes.
Yeah, I'm not able to.
Take your time, no hurry.
I should do so.
Yeah.
Is my presentation visible?
No, I am seeing. Now it is visible. Excellent.
Okay, thank you, Dr. Vinay. Am I audible?
Yes, very well.
So thank you, Dr. Vinay, for the very nice presentation. And my last linear EUS anatomy, I said I will bring Dr. Vinay to talk about the alpha maneuver because he has invented, I think you have listened from the horse's mouth. And the two basic topic, and I'm going to talk about contrast EUS. I will try to cover my topic in another 20 to 25 minutes. So the roadmap for my talk is, what is the technique of contrast EUS? Does it work in our clinical practice? It doesn't worth the cost because it costs to the patient. What is the opinion of house we cannot discuss, but definitely I'm going to give my opinion using the contrast EUS in your day-to-day practices, worth or not. So where I will talk about, does it worth the cost using the contrast EUS? So if you look at here, so solid pancreatic masses are challenge for the physician and endosonographer because 15% of the pancreatic cancers are not adenocarcinoma. They may be neuroendocrine tumor, they be metastasis from kidney, colon, breast, melanoma or lung. You may come across with the lymphoma or you may come across with the benign histological type like autoimmune pancreatitis or so. This is the prospective study from France, which shows that when you take a EUS guided FNA from the pancreatic solid mass, 55 to 70% are only adenocarcinoma, 15 to 25% are inflammatory tumor, 6 to 15% are neuroendocrine tumor, and 5 to 15% are metastasis or rare histopathological type tumor. Similarly, the pancreatic masses are challenged not only to the endosonographer, but they are a challenge to the gastroenterologist as well as cytopathologist, because 6 to 15% of the Whipple procedure performed for suspected pancreatic cancer, they turns out to be benign disease. And pancreas is the third most common organ where the misinterpretation of normal cellular constituent lead to an erroneous neoplastic diagnosis. So pancreatic head masses are challenged both for endosonographer and gastroenterologist, as well as many of the time for the cytopathologist and histopathologist also. This is another study from the France, and what they have seen, out of 373 patients who underwent Whipple surgery, 33 patients, that is 8.8% of the patient, the disease was benign. EUS guided FNA from the pancreatic solid masses has very high sensitivity, very high specificity, very high positive predictive value, but the negative predictive value is not good. So what should we do to make it better? We can improve situation by using the better EUS needles, that is cutting needles, or by performing the contrast EUS, or by doing the elastography. So why do we need contrast EUS? Still we know that EUS and EUS FNA is a procedure of choice, but many of the time chronic pancreatitis with the head mass have a poor sensitivity of EUS guided FNA. Patient who is on anticoagulation or has a coagulopathy, or there is an intervening vessel between the mass and your gut lumen, or many of the time you may get the false negative results. CT and MRI cannot perform in cases with a renal failure or patient who has a contrast allergy. I think contrast EUS can be done because it can be used in a patient of renal failure or patient who has a contrast allergy. And you can get the better characterization not only of pancreas but a node just in the GP wall. So the common applications are benign versus malignant pancreatic tumor differentiation, benign versus malignant lymph node differentiation, knowing about GIST has a malignant potential or not, identifying the tumor area from where you can take the EUS guided FNA, so you can increase the accuracy of FNA, especially in a patient of chronic pancreatitis with a head mass or patient of a pancreatic head mass which present as a recent onset to pancreatitis. Decision making in cases of inadequate or misleading FNA, and further research in the form of therapeutic delivery of the drugs. Now, the equipment needed, there is a pre-installed software in the EMU2 or in the Aloka machine. The EUS scope has a band, the broadband transducer, which can emit more ultrasound radiation. So the equipment also needed for the contrast EUS as well as for the elastography. Now, when we talk about the contrast EUS, the fundamental is, as we know that the vascularity, whenever you do the Doppler, you can only pick up the Doppler signal from the large vessels. You cannot pick up the Doppler signals from the small or the perfusion level vessels. And when you do the contrast enhanced Doppler EUS, you may get the blooming and the motion artifacts. And as we know that the vascularity help in identification of benign and the malignant lesion, that is the basic of the CT scan. But with the help of Doppler, you cannot differentiate either on the basis of Doppler EUS or contrast enhanced Doppler EUS, because I have already discussed the Doppler EUS cannot pick up the small perfusion level vessels pickup, and the Doppler contrast enhanced Doppler EUS is associated with the painting and the blooming artifacts. On the contrary, this vascularity help in knowing about the benign versus malignant in the CT scan or in the MRI. So to overcome the problem of Doppler or the contrast enhanced Doppler EUS, contrast harmonic EUS, it allows the detection of the microbubble within the slow flow vessels or at the perfusion level. So this is the video where you can see the contrast is flowing in the small blood vessel at the level of perfusion in the pancreatic parenchyma. And on the basis of this, you come to know, are you dealing with mass or are you dealing with malignant? Now, what are contrast agents? Contrast agents are the microbubble, which is consists of a central gas that is different in the sonoview, or it is different in the sonozoid or the definitive. And there is the outer shell, which is composed of galactose, palmitic acid, or phospholipid in the different contrast agents. And commonly used contrast agents are three: definitive, sonoview, and sonozoid. In our country, we have a sonoview, which is an outer lipid layer, and the sulfur hexafluoride as a gas in the sun. And these contrast agents are 2 to 3 micrometer, and the preparation I am going to talk in the subsequent slides. Now, it is very important for us to understand how the contrast harmonic EUS work. So if you look at this diagram, when the ultrasound waves goes to the tissue, there is a generation of the fundamental frequencies, and there is a secondary harmonic component also generated. But with the normal tissue, the fundamental component of the waves is much larger and higher in comparison to the second harmonic component. While cases where you use the contrast agents, the microbubble produce the fundamental component, but the second harmonic produced by the microbubble contraction and the expansion is much larger in comparison to the fundamental frequency generated by the tissue. So you have the second component using the contrast EUS, and you are knowing the vascularity of that particular lesion. You are not getting the signal from the surrounding tissue. Once you know the vascular pattern of a diseased organ, then you can predict, are you dealing with the benign disease or are you dealing with the malignant disease? Now, what is the concept of mechanical index? Because whenever you are doing the contrast EUS, you use the mechanical index of 0.1 to 0.6. The concept is, if the mechanical index is less than 0.1, because the ultrasound wave has a positive and the negative wave pattern. In the positive wave pattern, the microbubble compresses, and in the negative wave pattern, the microbubble expanded. So compression and the expansion of the microbubble produce the secondary harmonic images. So if the mechanical index is less than 0.1, the bubble only oscillate in a symmetrical manner and they produce the linear scattering. They don't produce the compression and expansion of the bubble. And if you use the mechanical index more than 1, what happened is there is a burst of these bubble and you will get the glitter artifacts. So always you keep the mechanical index between 0.1 to 0.6, and commonly used mechanical index is 0.4. At this mechanical index, the contrast agents, that is a microbubble, they constrict and expand and they produce a secondary harmony which is much higher than the surrounding tissue. And the signal which you get from the microbubble, and the microbubble give the status of the perfusion of that pathological organ. So once you know the perfusion status of a pathological organ, you can predict, are you dealing with a malignant or are you dealing with a benign process? I think this is the basic concept of contrast EUS. The procedure always use the 16 to 18 gauge lead cannula, put at antecubital vein or put at the larger vein. You inject the contrast agent slowly, followed by the saline flush. The rate of injection of the contrast is 1 ml per second, and saline should be flushed rapidly at around 5 to 10 ml. Always produce a dual screen is displayed. On the one side, you will get the contrast EUS image, which is black, and the conventional B mode imaging. As I said, use the low mechanical index. The arterial phase consists of 10 to 20 seconds, which lasts for approximately 30 to 45 seconds, and venous phase, which lasts from 30 seconds to 120 seconds in sonoview. And if you use the sonoview sonozoid, it can last for more than 2 or 3 minutes. So how to constitute the contrast agent? It is very well depicted on the box, but this is the method. The pre-filled syringe should attach to the canister. The contrast agent should be attached in the inner side. You inject the saline, pre-filled saline, which is around 5 ml, and then you hold this between the palm of your two hands and try to rotate clockwise, anti-clockwise like this. Never do like this. Never do the to and fro movement with your fingers, because otherwise it is going to burst the particle. Once you have mixed the contrast agent, load the needle back and always use the 16 to 18 gauge cannula. As I said, you inject the contrast agent 1 ml per second, and it should be in the straight position of the needle. It should not be on the side. Once you inject around 2.5 ml of the contrast agent, change it and inject around 10 ml of the normal saline. And once you do it, within 10 seconds, you started seeing the bubble, which shows an arterial phase, which lasts for 30 to 40 seconds, followed by the venous phase. So what kind of contrast pattern you see in the various pancreatic tumor? If you have a cystic tumor of the pancreas, you will get the avascular pattern. If there is a pancreatic cancer, you will get a hypovascular. And from where you are going to compare? You are going to compare with the surrounding pancreatic parenchyma. Isovascular, like similar like the rest of the pancreatic parenchyma, and hypervascular when it is more than or it is equal to the surrounding vessel. So contrast agent shows hypervascular lesion, which suggests about the neuroendocrine tumor. So this is the multi-center French study which shows Adenocarcinoma in 95% of the time is hyposignal or hypovascular, while the neuroendocrine tumor 100% of the time is hypervascular, and the chronic pancreatitis in 15% of the cases you may get the hypovascular, while 85% you will get the hypervascular. Similarly, the monocentric Japanese study again shows pancreatic adenocarcinoma 95% hypovascular, while neuroendocrine tumor 100% time hypervascular, chronic pancreatitis 20% hypovascular, while 80% iso or the hypervascular. So these are the few videos. This is the contrast image and this is a B mode image. You can see the contrast agent has come into the artery. You can very well appreciate it. You can see the arteries which is showing the contrast agent, but the lesion is absolutely hypovascular. You see a little bit of the contrast, but it is hypovascular in comparison to the rest of the pancreatic parenchyma. So the hypovascular lesion in comparison to surrounding pancreatic parenchyma indicate that you are dealing with the pancreatic adenocarcinoma. So if your FNAC is negative, then you can do the contrast EUS and you can tell your surgeon in all probability this is a malignant tumor. On the contrary, if you look at here, there's another hypovascular lesion. This is a contrast EUS image. You do the contrast EUS and look at here, very important. The hypoechoic area which was so large now becomes small because the rest of the surrounding pancreatic parenchyma shows then evidence of inflammation. So that indicates that this pancreatic tumor has an inflammatory component also, and the real pancreatic tumor is that small. Now, when we talk about the neuroendocrine tumor, this is a very good study again from the France, which shows the contrast EUS has a better accuracy and better negative predictive value in comparison to the KI index or the size. Because for the neuroendocrine tumor, if the tumor size is more than 2 centimeter or the KI index is more than 67, that indicates you are dealing with a neuroendocrine tumor which is aggressive. But here they compare with the contrast EUS, and that shows if the neuroendocrine tumor has a heterogeneous pancreatic parenchyma, then the negative predictive value of knowing that you are dealing with the aggressive neuroendocrine tumor or not is around significantly higher in comparison to the standard criteria which is used for aggressiveness of the pancreatic neuroendocrine tumor. So look at here, this is a contrast mode image and this is the B mode image. Small hypoechoic lesion, these are the splenic artery and splenic vein. Look at here, contrast agent has come into the artery, the vein is still not appeared. Now you see a hypervascular lesion. Can you see it? That very clearly shows that you are dealing with the neuroendocrine. It is hypervascular than surrounding pancreatic parenchyma. It is similar to the arteries. Another example, a hypoechoic tumor with the splenic vein thrombosis. And if you look at the contrast agent started coming, and you see this is the normal pancreatic parenchyma. So the tumor is hypervascular. The thrombosis in the splenic vein is hypervascular. That indicates you are dealing with the neuroendocrine tumor with a splenic vein, which is because of the tumor obstruction. Now the role of contrast EUS in the cystic pancreatic tumor. Contrast EUS is useful in the cases of differential diagnosis between macrocystic serous adenoma or the serous cyst adenoma in the side branch IPMN. Because many of the time, the macrocystic variant of serous cyst adenoma in the side branch IPMN is a confusion. So if you do a contrast EUS, then you will come to know, are you dealing with the serous cyst adenoma or are you dealing with the side branch IPMN? In the cases of unilocular cyst with a thickened wall, contrast EUS is useful in finding out the nature of the thing. In cases of a suspicion of mural nodule versus mucinous globule, contrast EUS can perfectly differentiate. So if you look at the video, this is the cystic tumor with a component in the base of the cystic tumor. And when you do the contrast EUS, it shows there is a vascular structure. That indicates you are dealing with the mural nodule, not the mucinous globule. So if you find a vascular signal which is present in the mural nodule, not in the cases of mucinous globule. On the contrary, look at the second video. This is a cystic lesion with a solid component, could be a mucinous globule or the mural nodule, and you look at the contrast EUS, there is a no vascular signal inside. That indicates you are dealing with the mucinous globule, you are not dealing with the mural nodule. So that is very useful, and then you can target the mural nodule, otherwise you just aspirate the cyst fluid. This is another case where we took an FNA in a cases of chronic pancreatitis 3 times, and all the 3 times it was negative. But while doing the contrast EUS and elastography, what we find that it appears to be malignant. So what we did is we did the contrast, we did the elastography, and we did the contrast EUS. So if you look at the elastography, the majority of the area is blue, which indicate the heart, and we did the contrast EUS, and this is the area which is hypovascular or hypoechoic. And we target our area of FNA and it turns out to be positive. So contrast EUS and elastography is useful in some cases where you are getting the negative FNA. This is the meta-analysis which shows the contrast EUS has a sensitivity of 94% with a specificity of 89%. This is another 2 meta-analysis. Now, when you compare the contrast EUS with the CT scan, it shows the sensitivity and specificity of contrast EUS is higher than MDCT in small pancreatic tumor, which is less than 2 centimeter. So less than 2 centimeter pancreatic tumor, where the MDCT is not as sensitive as contrast EUS situation, for the small pancreatic lesion, which is less than 1 centimeter, cannot be picked up, and you have clinical index of suspicion is very high, then you can do the contrast EUS. Now, when you compare contrast EUS with the EUS guided FNA from the pancreatic masses, that shows the contrast EUS and the EUS guided FNA. 5 adenocarcinoma with the false negative results shows hypo-intense echo signal in the contrast EUS. So if your FNA is negative, but if you are getting the hypo-intense signal, then you should have a high suspicion that you are dealing with the pancreatic adenocarcinoma, not the inflammatory mass. These are the 3 studies which shows an incremental effect. If you do a contrast EUS, you target the area which is hypovascular or hyposignal. So in all 3 studies, there is an incremental yield of 10%, and the number of passes was significantly low while using the contrast EUS in comparison to when you use the B mode image. This I have already discussed. I think the time intensity curve, I also personally don't know practically, so I'm going to skip these slides. Now, the role of contrast EUS in the GIST, to differentiate between the high-grade malignancy versus low-grade malignancy. If you find a regular vessel in the GIST tumor or homogeneous enhancement like here you are seeing, in comparison to irregular vessel or heterogeneous enhancement like in this cartoon, you can differentiate, are you dealing with the low-grade malignant GIST or are you dealing with the high-grade malignant GIST? This is a recently published meta-analysis which shows that discrimination between the benign SMT and the GIST EUS has very high sensitivity and specificity. And this is the 5 studies of 143 patients, which shows has a significantly good potential, very high sensitivity and area under the curve of differentiating, are you dealing with the high grade versus low grade GIST. This is response to the chemotherapy. Patient with the abundant intratumoral blood flow, that indicates if the tumor has a abundant intratumoral blood flow, then the chemotherapy will be more effective and the progression-free survival may be there, but it is still in the investigational phase. You can plan about the surgery. Contrast EUS is unable to better visualize the vein as well as artery invasion, or it can differentiate a true tumor versus the inflammatory component around the tumor. So it helps in the surgical planning, selective cases, and sometimes the microbubble can be used as a therapeutic agent. So it does not worth cost. Why? Because it's still not used in the clinical practice. Lack of experience at majority of the centers. Machine cost and the contrast cost make your procedure costly, and accurate interpretation also required. If you ask my opinion in selective cases, it is useful, especially in the pancreatic head mass of indeterminate etiology, chronic pancreatitis with the head mass to know about the malignant potential, selective cases of cystic neoplasm to differentiate a side branch IPMN versus macrocystic serous adenoma, or mural versus mucinous globule. Post RFA, I think Sundeep may be able to tell in his talk, when you do the RFA in a patient of neuroendocrine tumor, if you do the contrast EUS and still the tumor lightened up, that indicate you have not done the complete RFA. Contrast EUS guided FNA can be done in selective cases. Small neuroendocrine tumor 3 to 4 millimeter can be picked up with the help of differentiation of GIST. GB sludge versus mass. Tumor-effective mass versus GB sludge can very well be differentiated with the contrast EUS, and for research in the targeted therapy is still in the investigational phase. So to conclude, my dear friends, contrast EUS is very promising technique on horizon, but tissue is still an issue. These techniques are complementary, not replace the FNA yet now. Help to target the area of EUS FNA. Can these techniques replace FNA? I think it's still a long way to go. Much more data required. But the advantage is these techniques has a short learning curve. Thank you for the patience here.
Thank you, Rajesh. Thank you very much. Very, very exhaustive coverage of the contrast EUS. There are questions for you which we will take up after we listen to Sundeep. So
Okay.
now Sundeep will talk about tips and tricks of EUS, FNA and FNB. Very, very important topic for practice. Sundeep?
Can you hear me?
Yes.
Rajesh, can you switch off your slides and I can share my screen?
I'm doing. Is this okay?
Yes.
Why I'm not visible on the screen?
You have switched your video camera off, I think.
Okay, is that okay?
I'm not sure. I'm not seeing anybody now. So
I can see your slides.
okay. So I'll start my talk here. Thank you, Rajesh, for a wonderful talk. And EUS guided tissue acquisition is a very important role. I think of all interventions, if you take in EUS, 90% still tissue acquisition. 10% is rest of the procedures. And it's mainly required because tissue is always the issue. We need to know the diagnosis before we contemplate on any kind of therapy, be it medical, be it interventional EUS, or be it surgical, or do nothing. And when do we consider EUS FNA? When other methods of tissue acquisition are challenging, not possible, or inferior. Of course, if somebody has a lesion which is peripherally located on the skin or subcutaneous area, percutaneous FNA is a way to go. But if the deep-seated lesions which are next to the GI tract, then EUS FNA is very, very useful, and it gives a remarkable yield. Just to show to the beginners how does EUS FNA work, this is how the D of the EUS field of view. Imagine this star is the tumor and need to target it. You bring it below the D of your EUS frame. So between, say, 6 o'clock to 4 o'clock degree, and then you pass your FNA needle inside. This is the whole principle. So the aim of EUS FNA is to get adequate tissue for the cytopathologist to interpret and give a meaningful answer. This is the only aim that EUS adds. Of course, if you have a large amount of chunk of tissue or more of a core tissue, then you can do immunohistochemistry, you can see the architecture well, and you can do special stainings. So with cytology, the yield can be variable by EUS FNA, and that's why multiple needle passes are required. By needle pass, we means once you pass a FNA needle through the hollow of the channel and move it to and fro inside the lesion, generally 10 to 15 times, that's one pass. You take out this needle, expel the material out in the slide or the various containers that you have, and then you make a second pass. So that's what a pass means, not movement 10 times inside in one passage of the needle. That's equal to one pass only. And placing an EUS FNA needle into the lesion is not equal or not going to ensure that you get diagnostic cytological material. So we need to do something more than just by placing the needle inside the lesion. And what are these things we need to do? Before I go on further, when we get a tissue or cytology specimen from the FNA, there are a few positives which we want. One is it should be fully cellular and as much cellular as possible. It should be good amount of tissue for the pathologist to say, I've seen enough and this is my answer. And preferably one needle should give you a complete job. The downside of EUS FNA is when you get blood along with the FNA. And this blood sometimes hinders with the cytological or histological evaluation. So these are the factors or methods by which you can improve your tissue adequacy. If you can have the pathologist in the room with the microscope, not just the pathologist. We need the microscope where it can be stained in and around the room and quickly seen before you take out the scope from the patient. So after each pass, you give some material to the pathologist who stains the slide and sees with rapid staining in the endoscopy theater. That's called as ROSE or immediate cytologic evaluation. Other factors which make a difference is the caliber of the needle. We know there are 3 calibers available. Then which type of needle, steel or nitinol, the needle design, whether the bevel is sharp and long, does the needle have a side port? Then some needles have a reverse or a forward bevel, and these are different designs which are coming up. Even the tip is now having a sharp core or a tri core at the tip. Then the presence of stylet in the needle. These stylets can be blunt or sharp. One must be aware which needle is he using. And these stylets protrude beyond the tip of the needle. And if you puncture with the stylet, which is blunt, and try to go inside the lesion, it will be too much of a struggle or may not be able to enter. And that's why one must be sure what type of needle before you actually start doing the FNA. Then the question comes of suction or no suction, very often discussed. How much to and fro movement in the needle should be done, and what is the speed of this to and fro movement? Then the concept of fanning technique, which I'll address to in my subsequent slides. And the new concept of getting core tissue. Now there are dedicated needles from various industry partners which give a good amount of core tissue, and that makes the job much better. The advantage is not only you get a cytology, you also get good amount of core tissue which can be used, and these are some of the names mentioned here. And last but not the least is how you prepare your slides, how rapidly you transfer the material from the hollow of needle to the slide, prepare it and put in the alcohol or dry it up. And last, the concept using cell block. Elastography, contrast enhance has all been covered. I think I'll skip it here. So what are the tips and tricks? First and foremost is target the lesion. The lesion has to be brought at 6 o'clock ideally. It should be in the path of the needle trajectory. The scope should be as straight as possible or in the shortest length possible, because then your movement of the needle is very easy, frictionless, and the amount of force which is applied at the handle gets transferred to the tip. If the scope is in a very long position, this force transmission is suboptimal at the tip, and we have to really struggle or put a lot of ergonomic strains on the shoulder, fingers, and so on and so forth. And if you make the scope short and straight, then the lesion sampling is easy. You need to use the big wheel to hug the mucosa, and that brings you very closer to the lesion. And it's better not to avoid elevator at the time of puncture. You can use it subsequently when you are adjusting the needle direction in the trajectory, so that fanning can be done adequately. So keep the lesion as close as possible to the transducer. If a needle is coming from right side of the screen, right upper corner, which is most people conventionally do except Rajesh who comes from the left side. So the needle, the lesion has to be at 6 to 8 o'clock. When the scope is in long position, the needle do not exit the scope because of angulation easily. So we need to protrude the sheath little longer than usual. In short position, the projection of the sheath is generally about a centimeter or so, but in long position, it can be 2 centimeters to sometimes up to 3 centimeters also. The puncture inside the lesion should be a quick jab or a staccato movement, like a jab, so that the needle tip is inside the lesion. You can adjust the guard so that you don't overshoot the lesion, because if there are any adjacent vascular structures, you can accidentally puncture them, which can cause risk of bleeding. Or if they're obstructed duct, say a bile duct in a malignant obstructive jaundice because of cancer head of pancreas or ampullary tumor, then you may sometimes go through the duct, which is unnecessary hindrance, because if your intent is not to drain at the same time, any contamination of the bile duct obstructed, which had a sterile environment before, will mandate an early drainage rather than a late drainage as you had planned earlier. Let me show you the fanning movement. If these are the nodes here comes the needle in one direction. Then you come back to the edge, keep the big wheel further up, go in different direction, again big wheel up, and maybe a little bit of elevator here. And this. So we have gone from this much to this degree. So generally about 25 to 30 degrees of cone can be made by using the fanning technique. This is my preferred speed, not too very fast and not to go very slow. You can go from one node to the other if they're adherent nodes or matted nodes. In the right panel, you can see this is a large lymph node, and an FNA has been done, and this is the path of the needle which has been taken. Fortunately, I could see the needle track path, and this is the cone which we have, or the degree of extent of the fan. I'm sure you can appreciate that. Because fanning gives the higher yield, and this has been studied earlier in a small study where even the first pass, if you do fanning versus no fanning, the yield from 57% jumps to more than 85%, and that's the importance of it. So if you do 2 passes, even this 85% will keep jumping higher. We should always avoid the blood vessels, interposing blood vessels, especially if they're big or if they're arterial, because they can be a bleed. In younger patients, most of these arteries go into spasm soon after and the bleed stops. But elderly patients or those who are having atherosclerotic arteries, or those who are on anticoagulants or antiplatelets, the risk of bleeding is more and can be significant. However, having said that, sometimes you're not able to avoid it in spite of the best efforts, or you realize it later. If you realize that you have gone through a vessel, as in this case, it's best to complete the whole job rather than coming out and then trying to find another path, because now you've already done the job. This was a portal vein which has been crossed in a patient who had a gastric outlet obstruction, and we could not go from the duodenal side. So from the stomach, as Vinay was showing in his alpha maneuver, you can see the pancreatic head across the portal vein from the stomach, and sometimes we need to do FNA to establish the diagnosis. The caliber of the needle, how it dictates, varies from personal preferences, but my personal preference is anything which is beyond the pylorus. I use a 25 gauge needle, and proximal to the pylorus, that is in the stomach or esophagus, 22 gauge is my preference. Before these core needles came, I was using 19 gauge if my intent was to get a core tissue. Often I could also get with 22 gauge needle, but 19 gauge with minimal suction or no suction would give me some core tissue. Also for lymph node, generally we use 22 or 25 needle wherever they are located. For pancreas, if you're hitting the head beyond the pylorus, that is from the duodenum, then 25 gauge is the preferred needle. One, it is easy to pass in and out in a long position. Also, the core tissue needles are many, as I showed earlier. Apart from the regular needles which can give you core tissue, but that's little more you cannot be sure how much chance of core tissue coming in there. So if your intent is upfront to get core tissue to establish a diagnosis, say for example, a GIST or an autoimmune pancreatitis or something where you need to do IHC, I think it's best to start with a core needle, and a quick core needle or a needle which has a side hole from Olympus is available. The Pro Core needle also has a side hole which is coming in all three sizes, and this can have either a forward bevel or a reverse bevel. The reverse bevel was in all three sizes, whereas the forward bevel is available in 20G. Then the new needle from Boston is the Acquire needle, which gives a good core tissue. Having said that, most needles are quite good. I think they are more than 90-95% efficient in giving you either a good cytology sample or cytology in addition to the core tissue. And these are some of the representative images of these needles which are available. If you look carefully at the Pro Core needle, it has a side hole with a reverse bevel about 4 millimeters from the tip. So this is the area from which the tissue comes inside. So we need to use a negative suction to get the hollow of the needle filled with core tissue each time so it cuts on the way backwards. Let me show you a video from the industry of a Pro Core needle. This is the tumor. So you go with the stylet inside, and once you inside the tumor, then you withdraw the stylet. Once the stylet is proximal to the side hole, and then you either remove the whole thing and apply gentle negative suction, or the stylet itself can be used as a slow pull technique. This is the forward cutting needle design. Instead of the reverse bevel, this is a forward bevel. So this one cuts in the way in. Then some of the needles have a springy mechanism, which is quite useful in tortuous anatomy, because this gives the strain on the needle sheath is much lesser, and it gives an easy and smooth insertion even in an angulated position. For example, if this is your position of the scope, for example, in a long position in the pancreatic head, you can bend the needle more, bend the scope more, and still the needle is able to come out. Those needles which do not have the spring mechanisms, it is difficult to bend them and also to protrude the needle beyond the sheath. But the spring type needles or the coil sheath allows the needle to project out of the sheath. And they can also be manipulated with the elevator. Often those which do not have these curvature or the spring coil, the elevation is difficult or more put strain on the elevator, whereas in spring type needles you can do that. And that also helps in adjusting the direction of the path of the needle. So you can go from the far end to the proximal end just by the lift of the elevator. And these are other designs which have a better cutting or a better visualization or more flexibility. If you use the needles which are made of the same material as the stents, and these are memory stents, and that's why the needle also has a memory, and they do not get deformed once you have even used in a very awkward position. Then some of the needles have the tip which are different. This is a shark core needle which has the teeth like a shark. One teeth is smaller than the big one, and it grasps the tissue in between. Supposed to be a good needle for tissue acquisition. And this is a new needle from Boston Scientific, which is a 3-pointed sharp teeth at the tip, and this gives a good core tissue with minimal of suction, or just by a slow pull you can get the tissue there. And this is what I mean. If you have the tissue expelled out in a container, if you have the strands like this, if they're purely red, it can be a clot. But if you see them carefully, you can sometimes see whitish area as you see it here, which suggests that this has a pure tissue inside it, which you can also examine ex vivo. If you expel the material on the slide, and if the entire thing is a clot, But you see carefully this area which is more whitish in area, and this is called as macroscopic on-site evaluation. We did a combined study with Rajesh and many Asian centers, and we found this technique quite useful because getting pathologists in the room each time is very challenging. They are busy people sometimes, and you cannot keep waiting for a patient who needs a tissue to be obtained. And so if you see a material like this, you're quite satisfied that you have got pure tissue and this is likely to give your inference. Use of suction is very subjective. Many people use 5 or 10 cc. Personally, I use for pancreas about 5 to 10 cc suctions. For lymph node, generally no suction, but if my first pass gives nothing, then I add 5 cc section. Other methods of applying suction is a slow stylet withdrawal technique, which some people say it's a placebo type of suction, but another way is to use a wet suction where you remove the stylet, fill the hollow of needle with saline, and attach the negative suction at the proximal end with the lock on. Once you inside the tissue, you open the lock, and as the tissue comes inside the hollow of needle, the fluid gets displayed into the hub of the syringe. This is the Archimedes principle, that the volume of the fluid which comes in the syringe is equal to the volume of the tissue which has come inside the hollow of the tip of the needle. But negative suction adds bloodiness, as has been seen many of this publications, including Rajesh Puri's publication. Negative suction, some people have gone to the extent of using the room suction machine which is put on the endoscope. This is one of the Japanese studies, and they found it was quite effective. Although we don't use it as a practice, but this was an interesting study I thought I'll share with you. Stylet, because most of the needles comes with a fixed stylet, it makes no sense in removing it and then using a hollow needle. Also the challenge of, not the challenge, but the confusion which can arise sometimes when you use a needle without stylet is that you puncture the GI wall, and that GI wall tissue can also be passed on to the pathologist, and they would not know whether it's the columnar cells are actually the malignant cells or actually the GI wall. So you must tell that it was stylet which was used or not. So presence of stylet sometimes prevents contamination from the GI wall. And again, some of these publications have come which showed that with or without stylet did not make any major difference. That study without stylet had a much more beneficial response. How many needle pass is always a question. For lymph node, generally 3 passes are good enough, 2 to 3. And for pancreas, maximum 7 pass. But this was in the era of no rows. But if you have rows, or if you can see that there's a white tissue in the first pass itself, you can probably stop there itself. Last few slides on the technique. So you see, this is a large mass, and they're doing the FNA. It's not always possible to do a very wide angle fanning. If you are far away from the wall, then your movement of the trajectory will be very minimal. So in this case, if I had come back more towards the surface and then change the direction, then I would probably get a much more wider angle. Finally, once you get the tissue, you have to quickly expel it on the slide and make a smear. It's better to make it yourself. Look at against the light. If you see some granular tissue, that's a good thing to have. And some material or one dedicated pass should be put in a bottle of formalin, which we use as for a cell block. And this is analyzed in the same way that we take like a mucosal endoscopic biopsy. This is one publication from ESG technical guidelines which say that factors that influence the number of needle passes made during EUS FNA. First, type, location, and the ultrasound characteristic of the lesion, presence of the cytopathologist during FNA, and level of their experience. So 2 things are dependent on cytopathologist, but also one factor is the type of the lesion, which Rajesh very nicely explained in the beginning. Suffice it to say that importance of rows provides a highly reliable diagnosis with excellent agreement with the final cytopathological diagnosis. So you need to have a pathologist if possible, especially if you're doing a second FNA. For suppose the first FNA which you did a few days back has come negative, no tissue, it is always advisable to have this time the pathologist. You can fix a time in such a way that both of you are available at that time and finish the job more effectively. Additional benefits of EUS FNA, they can get tissue for histopathology. So combined FNA histology and cytology increase the diagnostic yield and sensitivity for pancreatic cancer detection. Tissue is used for immunostaining. You can also do ancillary tests like culture, or if you suspect lymphoma, you can send the same sample for flow cytometry. Remember, this sample has to be put in saline. So the take-home message is confirm the lesion, target the lesion with the needle in preferably the short position of the scope, choose your needle gauge, set your own preference of suction depending on the lesion type or your own experience and the presence of stylet or no. This is your own preference which you can design with passage of time. I always use stylet. I always use a wet section technique. My preference is 25 gauge needle for most of the pancreatic lesions and the lymph nodes. Rose is dependent on many other factors apart from you, and ancillary investigations is dependent on what your differential diagnosis is. Thank you very much for your kind attention.
Thank you, Sundeep. That was a wonderful coverage of a really wide topic. Your coverage was fantastic. I think you covered practically all aspects of EUS, FNA, and FNB. So we have a huge number of questions. 31 questions are there. I don't know whether they're questions or comments. So let me open that. We had 309 participants in the seminar, which is a very good number.
That's impressive.
For a EUS webinar. So let me start from the beginning. There is the first question from Aditya Kale. Dr. Kale, can you take FNA by alpha maneuver from pancreatic head and uncinate lesions? How much safe is it? Risk of needle track seeding in the stomach? This is a very, very good question, and I think Sundeep answered it while showing if you want to take from the head, you have to go through vascular structures and you're going through the stomach. So yes, both your worries are correct. There can be bleeding, although personally I have done about 15 or 16 transvascular FNAs. I use a single 25 gauge pass, only one, and it has been pretty safe. I think Rajesh has also published some on that using a 25 gauge in difficult locations. So if it is extremely important, you should understand the risk and do it, and take only one pass, probably. Sundeep, what do you have to say? Hello, Sundeep? Okay, I think Sundeep seems to be not here. So there are other comments. Please suggest a good book for linear EUS and other advanced GI endoscopies. I think there are excellent books available from multiple authors. There is a book by Shyam Vadrachlu, Rob Hawes, and Paul Perkins. There are very, very good Japanese articles and books on the anatomy, linear EUS. So multiple things. We are also from the Asian EUS group coming out with a book which should come next year. So, but my suggestion is look at more videos rather than books. But I think I would say the book by Paul, Rob, and Shyam is a standard. Hamid Raina asked, should we keep big knob always up during alpha maneuver? No. It depends if you want to bring the structure of interest close to your transducer, which is not always necessary. So for example, body and tail, actually you have to keep big knob down. Otherwise you will compress the body and tail of pancreas. But to see the head of the pancreas, you have to, yes, you have to use the big knob. Not completely up, but some up. Ashish Agarwal asked a question, do you always use alpha maneuver or use it only for beginners? No, this is my standard maneuver for all cases. I shift to plan B, plan C only if I am not getting good windows, which does happen in about 5% of cases. This is my standard. Radhika is here. Radhika Chavan, very okay. Some tips and tricks to do EUS in surgically altered anatomy. Excellent question, Radhika. So, alpha maneuver is extremely useful in patients with surgically altered anatomy because you cannot enter the duodenum if for example, you have a patient with Whipple's. So, I would say do it entirely from the stomach. Don't try to enter the jejunal loops, the anastomosis. And Sundeep is back. So, surgically altered anatomy, there is no option from the duodenum. So, learn the alpha maneuver, do it from the stomach, and you will be able to see the head of the pancreas in almost all the cases. Or if it is the Whipple's, you will be able to see the anastomosis, the pancreatic duct, and the jejunum beyond. So, I would say do it completely from the stomach. Professor Hussain Aukasha, good friend, seeing the whole pancreas from the stomach can be achieved in most patients, but it is sometimes difficult, especially in obese fatty persons. Are there any tips or tricks? I think it's a pertinent and fantastic observation by Professor Okasha. He's very, very correct in this. If you have an obese patient, there's a lot of fat around the vessels, around the pancreas, and you may not get a good windows. Uh, so alpha maneuver, seeing the whole pancreas from the stomach can be difficult. The only way is if you can use your up a lot and try to bring the pancreas closer to your transducer. Very difficult in obese patients. KK Raval is asking a question. Hi KK, what is the role of balloon in EUS? Sundeep, would you like to answer that?
Yes, I often use a balloon in my practice, and mainly for if my intent of doing FNA is from the duodenum, and when my plan is to do in a short position, so it's difficult to predict upfront. So that's why I always keep a balloon there. But for body and tail, it's not very essential. So mainly for EUS FNA from the pancreatic head, if my aim is to get in a short position, which is my preference position.
Okay, thanks.
That helps in anchoring the balloon without
Right.
it doesn't slip out of the duodenum into the stomach repeatedly.
Right. Dr. Nikhil Gupta asks, what is the position in which you have shown the videos? Is there any change in the maneuver when the patient is prone or left lateral? So all my videos of, and I think Sandeep's videos and Rajesh's videos probably all are left lateral. Am I
Left
correct,
lateral.
Sandeep?
Yes,
Yeah.
all left lateral.
Yes, I think all are done in a left lateral position. Prone or supine position is usually used for some cases in interventional EUS, but for diagnostic EUS, almost everything is done in left lateral. Dr.
Agree.
Pradeep Agarwal, hi Pradeep. The question is to Rajesh. Harmonic imaging is good enough or not? Sonoview is costly in private. Very pertinent question. Rajesh?
Yeah, am I audible?
Yes.
So the two important things which come out of this question. First question is the Sonoview is sufficient? Is that the question?
The question is, Sonoview is costly. So harmonic imaging should be done. I guess he wants to know where it is absolutely essential
Understood.
because there is a
So
cost.
if you look at the data about the harmonic imaging in the pancreatic tumor, it won't give the vascular pattern which is supposed to be. It will be more subjective. While in the contrast EUS, you will give the objectivity. You have a very clear-cut demarcation from the surrounding parenchyma. When we talk about the cost, it is 2.5K per patient. So which I feel it is not a great huge investment in a patient where you are planning to do a Whipple's or not to do it, inflammatory versus malignant mass. So pure harmonic imaging may not be of that useful, and the data is also not available to differentiate that harmonic imaging is sufficient. The data is only available for contrast harmonic imaging, not pure EUS harmonic imaging.
Okay. Dr. Anurag Lavekar is asking a question that again goes to you, Rajesh. Do you suggest EUS FNA and contrast EUS in the same sitting for a doubtful pancreatic adenocarcinoma? I think you can answer, and then Sandeep also can give his views on this.
So if I am dealing with the suspected neuroendocrine tumor where I'm doing the contrast EUS, then yes, I can do it in the same setting. But if you're inflammatory mass or the adenocarcinoma where you are not having a negative result, so in the first pass for a suspected adenocarcinoma or inflammatory mass with the suspected malignancy, I do an EUS guided FNA. If my result is negative and clinical suspicion of index of malignancy is very high, then definitely I do contrast EUS, and during that sitting I do the FNA in the same setting. But first time in those scenario, I don't use contrast EUS. Like not all cases, negative EUS FNA with the high suspicion of index.
I think that's more. Sundeep, you will agree with that.
Yes, of course.
Yeah. So Pradeep Agarwal is asking a question. Sundeep, it goes to you. Should a cyst of more than 3 centimeter size be FNA'd?
So it depends on your patient's symptom, age, and so on and so forth. And the other risk features are there. Say duct is dilated upstream to the cyst. Then I would straight away subject the patient to surgery. Where the patient is, say, elderly, unfit for surgery, and the diagnosis is not very obvious, in such situation, I would like to do an FNA.
Okay.
So younger patient, maybe surgery is better.
Yeah.
Elderly patient surgery can be kept away because these are big surgeries. Pancreatic resections have their own risk of morbidity and even mortality, even in the best of the hands.
Absolutely right. So next, Rajesh, Dr. Ashish Agarwal is asking you, what will be the CH-EUS difference between a paucicellular serous cystic adenoma and IPMN? Interesting question.
So one is a serous cystic adenoma, second is IPMN, and third is?
That's it.
That's it.
Yeah. So if you look at the very good question.
Yes.
So when you deal with the macrocystic serous adenoma versus the side branch IPMN, where you may get confused that what is the nature of the lesion is.
Yes.
So if in a macrocystic serous adenoma, you may get this typical stellate pattern of the vascular structure which is seen in the serous adenoma. Number second, if there is a side branch IPMN which is acellular, meaning that there is no mural nodule, then you will get the avascular or no vascular signal in that. But if there is a mural nodule, the wall thickening is there, then you may get the enhancement of the wall or the mural nodule. That's why how you can differentiate, are you dealing with the macrocystic serous adenoma or are you dealing with the side branch IPMN?
Fantastic. I think that's absolutely right. Same question was asked by Dr. Nikhil Sonthalia. Nikhil, hi. So I hope you're happy with Rajesh's answer. There is an anonymous attendee who is asking, is FNB better than FNA? How many EUS sessions can be planned for a patient with negative results twice? Sundeep?
Look, FNB needles are a little more costlier than the FNA needle in a real-time world, and not everybody in India is insured. So that is important. Having said that, FNA needle also give a very good yield, which we had been using before these FNB needles came for last 4-5 years. So FNA needle gives as good a result. If you have a pathologist in the room and using FNA needle, I think that will probably suffice. But if you don't have pathologist, then it may be a good idea to have the FNB in the first go itself. Now the second part, if you have first time drawn a blank and the patient comes back later, in that situation, I think it's imperative to have the pathologist there, or this time you definitely use an FNB needle.
Absolutely. I totally agree. Another question from an anonymous attendee, EUS in post-GJ status. I think I have already answered that question. If it is only a GJ and if you can enter the bulb at least, then there is no problem. But if the duodenum is not there, it's a Whipple's, for example, and then there is a GJ. You do it from the stomach. When you have done a few patients of post-operative anatomy, you will realize that you get almost all the information that you need from the stomach. You can also take biopsies with little risk. So it is possible to give a good idea of what is happening at the anastomosis. and ripples or any other indication. For example, there is a small stone in the CBD. You cannot enter the duodenum. You can see it from the stomach. So Arun Arora is asking, it's a very common and interesting question. Sundeep, I'll give it to you. How to differentiate autoimmune pancreatitis from CA head of pancreas? Okay, the question is on contrast EUS. Sundeep, you answer it, then Rajesh will.
Okay, so both can present as a pancreatic mass,
Yeah.
and both can present as obstructive jaundice. Autoimmune pancreatitis, also both are males and generally they're senior citizens. So all these things are commonality between the two. They are a little more vascular than the autoimmune is a little more vascular than the anechoic or hypoechoic pancreatic cancers. So that's why when you take FNA, you also should get some cell block, a good cell block with the white core or with the core tissue to get the answer. One more thing you should know is that in the pancreatic duct will be traversing through the mass in autoimmune pancreatitis, whereas in malignant pancreatic mass, the duct is at the side. So if the duct goes through the mass, it is more likely to be autoimmune. If the duct is at the edge of the tumor, it is more likely to be a malignant adenocarcinoma type lesion.
Rajesh, how to differentiate on contrast EUS?
Yeah, so I will add on certain more point to Sundeep. In the cases of pancreatic adenocarcinoma, the distal pancreatic parenchyma will be atrophic, the duct will be dilated, while in autoimmune pancreatitis, the distal pancreatic parenchyma may be normal or swollen up, the pancreatic duct is not dilated. When you do a contrast EUS, the hypovascular pattern in the adenocarcinoma, while in the autoimmune pancreatitis, you will find a isovascular or maybe a little bit more hypervascular. So these are the differentiating point between the adenocarcinoma versus the autoimmune pancreatitis.
But you do need a biopsy, right?
We do need a biopsy, no doubt about it.
Yeah. Okay, Sanjeev Kar has asked indications for FNA-B. So, Sandeep, are there any patients in whom from the start you say, no, this patient I will use a biopsy needle and not an FNA needle?
Yeah, so first is autoimmune pancreatitis, second is GIST, gastric stromal tumors, or leiomyomas, esophageal wall tumors. Any esophageal or GI wall tumors, I will use a core biopsy needle. And lymphomas, I will also use a core tissue because immunohistochemistry is very important there.
Okay, yes, I think this is. KK Rawal has asked two very good questions. Both are to Sandeep you. Does rose help always? And the second question is, any tricks for FNA from thick wall in GIT?
So rose, if you have the luxury of rose, I think always use that bouquet of flowers and get the pathologist in the room. And the thick wall of the GI tract is not a hindrance to the FNA at all. Even if it's there, you can go through it, and even you can take it from the, if you're saying that the mass is beyond the thickened wall, then you can go through the thick wall. That may be part of the tumor itself actually, which is infiltrating now the GI walls. For example, in pancreatic head cancers or pancreatic cancers which infiltrate the stomach wall or the duodenal wall, you can also do it from the wall of the GI tract to get some tissue.
So I think the question he was asking is, if you have a patient with a thickened gastric wall and you are asked to biopsy the stomach wall.
I'm sorry. So yeah. This is a situation where I will do it in two ways. The endoscopic way of taking multiple biopsies at one place, that is called well technique or digging at one area, or you can take a snare biopsy for the thickened gastric folds. If these two standard techniques are failing, then I would use a core tissue needle to get a good chunk of a core tissue from the gastric wall, like in Linear plastica.
Okay, now we have a question again from Pradeep. He's very inquisitive. So I'll give this to Rajesh. Rajesh, should we aspirate the fluid for cytology from the cystic lesion with a 25 gauge needle? So what needle do you use to aspirate fluid?
Okay, Dr. Vinay, I will answer in the two form. One question already put up and one question was not asked. You only aspirate the cyst cystic lesion of the pancreas if it is indicated. Number
Right.
second, if you aspirate, the yield is accuracy is only 45 to 50%. Number third, aspiration with 25G needle is not possible if it is mucinous. It will be very difficult if it is serous. So better to use either 19G needle or 22G needle.
Okay. I think absolutely I agree with you on that. Another question from Pradeep. Sundeep, you answered that. If you are in doubt on IPMN, when would you do a biopsy and when would you leave it alone?
So if it's a main duct IPMN and there's a mucin projecting out from the papilla on side wing endoscopy, that's a sine qua non of main duct IPMN. So in that case, if I have some kind of a villi which are projecting out from the either papilla or from the fistulous opening in duodenum or stomach, I can take biopsies from there.
Okay.
The second situation is where you do not have this and you have a cyst, like a unilocular cyst. If they have a mucin plug or a mural nodule, in that situation you can take it, but I would take Rajesh's help and get a contrast enhanced EUS to look at whether those mural nodules are actually mucin plug or the tumor manifestation only. If it shows a vascularity, then I would subject those things for surgery straight away, because that's a predictor of a malignancy or neoplastic malignant transformation in the IPMN.
Now, Taufik is asking, he's from UAE. Thank you for joining us. How do we manage if immediate cytology evaluation, I think he means ROSE, is not possible? So, okay, Sundeep?
Yeah, if not possible, that's what we're doing. 90% of the cases are, in spite of the pathologists in the hospital, we're not able to get them in the room. So we do it our way. As I said, you choose the needle of your choice, but inspect the specimen that has come in the needle when you expel on the slide yourself. Don't depend on anybody else in the room, because you're responsible for the entire procedure. And if you see a white core tissue on the slide, that's a pure tissue. You can actually make a slice of it with a surgical blade and set it separately in the cell block. And if you get luxury of these cores longer, then you can make slides out of it also and send that for a cell block. Having said that, even the red cores, which are predominantly clots, may have entangled whitish tissue inside. That can also be used for cell block. So cell block and cytology both should be sent in all patients.
So KK Rahul is asking which needle to use for liver biopsy. Rajesh, you want to answer that?
Yeah, I always use 19G needle.
19 gauge. You use a 19. You don't use the FNB needle.
22 sometimes.
Okay.
Yeah, 19G FNB needle I'm talking.
Okay.
19G FNB or 22 FNB needle.
Okay.
If I use the routine needle, then I use 19G needle. If I've got an FNB needle, either 22 or 19G.
Okay.
And I always expel the material with the saline, not with the stilette.
Okay.
Because it breaks the material.
Right. Sanjay Banerjee is with us. Okay. Hi, Sanjay. What is the role of EUS elastography in CA pancreas? We didn't discuss it much, but Rajesh, you want to just give 2 lines?
What, can you again ask the question?
Role of elastography in CA pancreas.
Yes.
Very briefly, yeah.
Very briefly. Elastography is, one is qualitative, one is quantitative. Qualitative is on the basis of color pattern, and quantitative is on the basis of strain ratio and the hue histogram. Now, recently the paper started coming that qualitative is better than quantitative. Earlier people were feeling that hue histogram and the strain ratio is better, but it has seen that the value of the strain ratio differ in different patients, ranging from 177 to 195 to differentiate malignant versus benign. So the qualitative elastography is useful, and especially in my practice, because it has no cost addition, I use targeting the FNA.
I think that's excellent. That's correct. There is a question from Amar Abul Magad. Can we repeat wet suction? So I guess what he is wanting to ask is, if you have taken one pass and then second pass, do you again do wet suction? Sundeep?
Yes. So my subsequent passes also are wet suction. And if the first pass is showing too much blood in the hub of the needle, my second pass has either no suction in it or very minimal suction. This is how I titrate.
There is a question from an anonymous attendee. I think Rajesh has done work on this. Can you take FNA from right adrenal gland?
Yeah, we can very well do the FNA from the right adrenal gland. You keep the scope in the second part of the duodenum, shorten it, focus the kidney by making the anti-clockwise rotation, and from anti-clock to clock, when you rotate, get to the aorta, right, you can find the right adrenal which is enlarged, and you can take FNA.
Yeah, I think you have some paper also on that. So,
Yes.
and the next question is how to reach the uncinate process from stomach. I think I showed two videos. Basically, you have to first see the head, see the IVC, see the aorta. So for that, you have to tip your scope up, turn clockwise, and withdraw a bit from the head. And you will see between the aorta and mesenteric vessels the uncinate process. Please watch my videos on the YouTube. Just type alpha maneuver, and if there is any problem, write to me. I will send you some more videos. Okay, is there any study on EUS guided portosystemic shunting? There are animal studies, there are no human studies. Very, very early literature coming. Hopefully, we will have better studies later. Ravi Chandra, hi Ravi, asking EUS characteristics of abnormal papilla and indications of FNA from papilla. Oh my God, very good question. Who will take it? Sundeep?
So you can see the papilla with both radial and linear scope, and my preference is to use the linear scope in a short position. I fill a lot of water in the duodenum to efface the duodenal folds and remove the bubbles at the time when I want to see the papilla carefully, and also sometimes give a Buscopan so that the duodenum is paralyzed. And then I try to get both the ducts PD and the CBD converge at the papilla. We see a small hypoechoic mound there. If generally this is about less than a centimeter in size, which goes from the surface to the deeper mucosa and up to the propria also. Even a little bit projection into the pancreas as well, you can see. So based on the experience, you can see that if this is uniformly hypoechoic, a little bit of irregularity, that's fine. But if the duct upstream to that is dilated, then papilla is most likely the cause of a problem, unless you're suspecting a colorectal cyst, in which case you may not have both the ducts originating from the papilla. There will be some kind of a division where the minor duct crosses the CBD, dilated CBD. So papilla visualization is best in short position, water in the duodenum, paralyze the duodenum, and very gentle torquing movement right to left with both the ducts converging at the papilla.
So now there are lots of questions remaining, and I don't think we have so much.
Answer it later. We can answer it later.
Yeah, I think maybe I will take two more questions out of this. Jayant Samanta is asking the strategy to be adopted for transvascular FNA. There is no strategy. You have to just stop the Doppler, use a 25 gauge needle, and make single pass. Don't go multiple times. If you tear the vessel, you will be in problem. However, it also depends upon the size of the vessel you're traversing. So, if it is a very, very big vessel, then obviously one single 25 gauge pass is enough. And then post procedure, please observe. See if there is any bleeding. Most of the times, there will be a small hematoma formed there, which is not going to give any trouble. But if it is a significant blood, then you will have to involve your friends, surgical and radiology colleagues. So do it only if it is absolutely essential. I'm not saying it is safe. The data is very, very limited, but we do it in conditions where we absolutely need the biopsy and there is no other way. That's the
I will add here that not to use the core needle if the vessel is there.
Yes.
And also use the thinnest gauge needle, that is 25 gauge needle.
Absolutely. Totally agree. So any maneuver that helps in easy entry of linear EUS down the upper esophageal sphincter, most of the scopes nowadays are pretty good. Slide your scope over the tongue. So initially what I do is once I am across the tongue, I use my up control and gently slide at a slightest resistance, come back. If you are sliding smoothly, then up is done down. You will see the cricopharynx and then gently go into the cricopharynx. Okay, then I think we'll take one last question. Ajay Choksi, hi Ajay. Do you take liver biopsies from both lobes regularly? Very good question. How do you take a biopsy from the right lobe of the liver? Sundeep?
So right lobe is taken from the duodenum first part, where you're in long position, you see the segment 6, which is just above the duodenum, and you can take it from there. And the left lobe you take from the G junction or the proximal stomach. So we are doing currently a study of comparing percutaneous versus EUS guided liver biopsy, where the pathologist is blinded, and we give both the sides and use 19 gauge needle, as Rajesh said, for the liver biopsy.
So we have stopped using percutaneous for more than a year now. All the liver biopsies we are doing EUS guided, very, very safe, excellent technique. And I know more publications on this randomized study is needed, but our belief is that we are